Dear friends, uh, today I am going to discuss about the brain cooling, the current status. We all know that toxic ischemic encephalopathy is one of the commonest reason for neonatal ICU hospitalizations. And as far as current status is concerned, probably brain cooling is the most evidence-based treatment as far as today's scenario is concerned. So I'm planning to do with this objective that what is the current status of therapeutic hypothermia? What is the evidence behind this? What are the controversies behind this therapeutic hypothermia, specifically when we are talking about low middle income countries, and what is the current status of treatment? If you really want to know that what is the objective of today's talk, so it is the selections of the right brain. We want to know which brain is going to uh, get the best evidence based management from therapeutic hypothermia. That means the infants having moderate to severe encephalopathy, we are who are falling within a therapeutic window where we can offer therapeutic hypothermia to prevent further damage and to have a good outcome at 18 to 24 months of age. If you look at the prevalence, the incidence of hypoxic ischemic encephalopathy in the high income group country, is around 1.5 per thousand, whereas in the low middle income country, it is almost 20 times higher as compared to high income country. If you look at the death and disabilities, the previous data of 2005 cool cap study and the NICSD study, they found that the death and disability was in the range of 44% with the same type of therapeutic hypothermia treatment. But over the years, the mortality has decreased from 44 to 29%, which was present in the optimizing cooling strategy trial of the NICSD, where the patient was falling under the usual care of 33.5 degrees Celsius. If you look at the death and disability in the low middle income country, it is very high. It is in the range of 50% or sometimes it is more. Out of all these survived, maybe 40 to 55% of HI treated with therapeutic hypothermia, they will still suffer substantial neurological disability in the future, or they will die. Look at this pathophysiology. So after an acute insults of hypoxic ischemic, there is an episodes of primary energy failure where you will get a hypoxic depolarizations, decreased cerebral blood flow, decreased ATP, acidosis, and ultimately stimulations of excitatory neurotransmitter and calcium entry into the cells and ultimately cell death. There is a phase of reperfusion injury followed by resolutions of phase and known as a latent period that would generally last between 6 to 15 hours of the life. I think this is the time we call it a therapeutic window where we can offer the best possible treatment, and probably therapeutic hypothermia is one of them. Because beyond that, if you don't offer treatment, the secondary phase starts and injury continues to happen because of the secondary energy failures, and this injury is continuous till months and years and ultimately causing tertiary brain damage. And there are many neuroprotective strategies which which can prevent this further secondary phase injury or tertiary phase or tertiary brain damage injury. And we know that even if we offer the treatment of therapeutic hypothermia during this therapeutic window, but the outcome would depends upon the severity of moderate and severe encephalopathy, the type of treatment, the timing of treatment, maturity of the baby. In spite of the best possible treatment, death and disability can happen in up to 50% of the cases. If you look at the mechanism of actions, there is we all know this pathway, and these all pathway of hypoxic ischemia leading to anaerobic glycolysis, and ultimately these all three pathway would lead to production of free radicals. And if you look at what is the optimum treatment, which would actually act at different point of this flow chart, and ultimately decrease the productions of free radicals. There are only two treatment. That one is therapeutic hypothermia and erythropoietin. Because in the preclinical and clinical trial, they found that these two are, the one of the, the best optimum treatment which can prevent and decrease the productions of free radicals. Not only that, apart from therapeutic hypothermia, erythropoietin can also prevent in brain repair. They do erythropoiesis, angiogenesis, and ultimately neurogenesis. So, as far as the management is concerned, probably these two uh, can be considered as an optimal management for part of neuroprotection strategy. When we're talking about the selecting right candidate, we one thing is very clear that we should avoid hypothermia, because any increase in the temperature during the neonatal care would lead to death or disability. There is no confusion about that. And the other factors, which is modifiable factor, probably if the patient is hypothermic at the time of hospitalization, so the brain damage would be more and more. If the maturity of baby is less than 36 weeks, maybe 35 and more, 35 and less, the chances of brain damage would be less. If the patient is having a history of intrauterine growth retardations or fetal growth restrictions, probably we won't get the benefit of therapeutic hypothermia to the extent we expect in a appropriate of gestational age baby. If there is an intrauterine infections or, I mean, comorbidities like acquired infections in form of early onset sepsis, the benefit would be lesser. If you don't offer this treatment within that therapeutic window, you won't get the right benefit. So we have to select the right brain where we can offer treatment of therapeutic hypothermia to a target temperature of 33.5 degrees Celsius, and it should be offered within 6 hours. So our aim is to select that brain only. So let's start with what is the evidence of therapeutic hypothermia in high income group countries. So I have included these six studies, and when they looked at the outcome, death and disability at 18 months of age, and looked at the adjusted odds ratio by adjusting the moderate and severe encephalopathy. If you look at the CoolCap study in the 2005, they found the decrease in the death and disability in the range of 40%. However, it was statistically not significant. 2005, an ICSD study, they found 28% reduction in death and disability at 18 months, and it was statistically significant. 2009 Toby trial, they also found 15% reductions. However, it was not statistically significant. Again, a large study from Europe in the year 2010, they found 80% reduction in death and disability with a statistically significant study. 2010 China study, they also found 53% reduction in death and disability at 18 months of age, and it was also statistically significant. And 2011 study, ICE study from Australia, they also found, death and disability at 18 months were almost 23% lesser. So out of these six studies, look at the NICSD, Neuro trial, the China study, and the ICE study. They found statistically significant role of therapeutic hypothermia in hypoxic ischemic encephalopathy, specifically in high-income group countries. So out of all these study, I think all studies have used servo control. Uh, uh, I mean. Cooling therapy, whereas ICE study have used the ice gel pack. That was the non-servo control method. When these all four, five, six study, they looked at the outcome at 18 to 24 months of age, looking at the cerebral palsy. If you look at the cool cap study, they found 25% reductions, but it was not showing any significance. 2005 NIC study, they found almost I mean adjusted OR of 0.68. It was again non-significant at 18 to 24 months of age, looking at the cerebral palsy. Toby studies, Toby trial in the year 2009, they found almost a 33% reduction in cerebral palsy at 18 months. And Euro trial 2010 also found almost 85% reduction of cerebral palsy at 18 to 24 months of studies. And again, ICE study also found almost nearly 8% reductions. However, it was not statistically significant. Uh, so we have already discussed all this study that was done between the year 2005 and 2011. But recently, one of the study by under the NICSD in the year 2017, known as the Optimizing Cooling Study, what they have found that if you compare with the older study from the new study, overall death and disability were less and decreasing in trend. That it was in the year 44% in the year 2005, whereas it is now 29% in 2017. So even in the usual therapeutic hypothermia, I mean, where they have used the temperature 33.5 degrees Celsius, the overall, the incidence of severe HI mortality is also lesser. However, there was no difference in the cerebral palsy. So we have already seen that this therapeutic hypothermia is protective till 18 months of age. The next question comes as, does neuroprotections persist to childhood in high income country or not? So the 6 to 7 year outcome under the cool cap trial, what they have found that there was a 46% surviving children were assessed with VFIM, that is a questionnaire based study. They found that disability status at 18 months was strongly associated with VFIM ratings. That means they were lesser. 6 to 7 year outcome under an ICST trial, when they looked at the primary outcome death or IQ less than 70, they also found that there was almost a 25% reduction in the death and IQ less than 70. In 25% it was less, and it was statistically significant. And when they were adjusted for moderate to severe encephalopathy, it was not that significant. In the Toby trial, when they look at the primary outcome of IQ more than 85, they found that the infant where they offer therapeutic hypothermia, IQ more than 85 were better in the treatment group, and RR was 1.31, and it was statistically significant. Now, what about the safety? So, looking at the studies from the high income group country versus the low middle income group country, that is including NICSD, Toby trial, Cool Gel from JIPMER, and Fetch contrast material study from the same Civilo, they all found a similar type of outcome. In all the studies, they found that the thrombocytopenia was not uncommon. DIC coagulation abnormality were common between between 6 to 66%. The prevalence of PPHN was in the range of 10 to 25%, arrhythmia in the range of 2 to 5%. Sepsis was almost in the same range, that is 5 to 11%. And hypotension was also not uncommon in the range of 8 to 42%. So that means you can do these type of intervention, that is therapeutic hypothermia, in a neonatal ICU where level 3 care would be available, where you can monitor the cardiac monitoring, where you can do a intensive or invasive BP monitoring, where you have the facility to for a blood bank where you can offer platelet or other blood product transfusion, and you should have the facility for doing MRI brain so that you can counsel the parents regarding the long-term outcome. And obviously those infant who needs some occupational therapy and or neurodevelopmental assessment, you should have all the facility. So if you have all the facility of level 3 neonatal care, then you can offer therapeutic hypothermia at your place. Similarly, the Cochrane also found, including all these studies from the high income group country, they found the number needed to treat was 7 and the confidence interval was 5 to 10. That means if you treat 7 patients with therapeutic hypothermia, you can prevent one extra, death and disability at 18 months of age. So it's a very, robust study where the number needed update is very less with a, very narrow confidence interval. So that is why therapeutic hypothermia remains the most evidence-based therapy for hypoxic ischemic encephalopathy. And that's why the American Academy of Pediatrics and NNF have recommended that if the patients fulfill all the following criteria, then you should offer therapeutic hypothermia in this set of group. What are these? The criteria. If you look at the perinatal insults, so there should be convincing history of ischemic injury during the delivery, and it is a subjective criteria. Patients, gestational age should be more than 35 weeks, 36 or more than 36 weeks. Age at time of cooling should be within 6 hours of birth. APGAR score less than 5 at 10 minutes after birth. Resuscitation efforts required at 10 minutes or more than 10 minutes after birth. That means baby is still on positive pressure ventilations beyond 10 minutes of life. And cord blood samples or blood gases should be done within 60 minutes of age, and it should show pH of less than 7 and best deficits of more than 16. And while doing neurological examinations, patients should fall under moderate to severe encephalopathy as far as modified Sarnat staging is concerned. Here I'm just mentioning that while doing a clinical neurological examinations, we should better do a modified Sarnat staging rather than doing the Thompson staging, because if you do Thompson staging, there are studies where they found that some of the baby falling at the mild hypothermia, they could be offered therapeutic hypothermia. So to avoid this, we should follow the criteria led by the NICST and the American Academy of Pediatrics and NNF, that we should follow modified Sarnat strategy. What about seizures? Presence of seizures shows that the injury has already been happened to the brain, and probably we won't get that much of the benefit if the patients develop seizures within first 6 hours of life, even though they are coming within that therapeutic window, but their brain damage has already been happened, and probably we will not get the benefit of TH in that group. So we'll discuss about that after the studies. So what are these exclusion criteria? Severe IGR, normal EEG if you have done the EEG, continuous EEG monitoring, at least for 24 hours, inability to cool by 6 hours, any chromosomal abnormality, any systemic infections, any history of coagulopathy, any need for major surgery within the first 3 days of life, or severely ill or moribund patients, specifically the primary pulmonary hypertension of newborn. So let's assume that we have, I mean, selected the candidate. Then we have to check for the cooling checklist. We have to look for the equipment setup, treatment initiation within 4 6 hours, and maintenance phase. So during the maintenance phase, rewarming phase is the one of the important part, and the rewarming should be done 0.5 degrees Celsius per hour. We should avoid any rapid rewarming, because the incidence of seizure is very high if you do a rapid rewarming phase. And we always target a temperature between 32.5 to 34.5 degrees Celsius with a goal to achieve 33.5 degrees Celsius. So regarding equipment choice, there are many equipment. Broadly, we can divide this equipment into two categories: servo control versus non-servo control. If you look at the overall studies, almost 12 studies is being done using non-servo control methods, and almost more than six studies have used servo control. And what is the difference? If you look at this meta-analysis where the low-tech technique were used, and so in this particular meta-analysis by Rosso, Z et al., they found they used 3 trials involving more than 400 infants. They found that this low-tech method, that is the non-servo control methods of therapeutic cooling, when they were used, death before discharge were almost 40% lesser with a statistically significant reduction in neurological mortality was almost 55% less with a narrow, CI. Decrease in mortality or severe morbidity at 24 months were also less, in the range of almost 25%. So that means even if you are using the low tech method, they are also effective. Similarly, the similar in the NNF position statement in the year 2021 October, they use this forest plot of studies using fudge contrast material type of non-servo controlled therapeutic hypothermia and gel packs, and they looked at the outcome death before discharge. They found that the overall death before discharge were almost 35% less, and it was statistically significant. But they have made a statement that all devices are good. It's better to use servo control. But if you're using non-servo control method, you need a close temperature monitoring and better give a nursing care of one with the ratio of 1:1. So if we have the facility of servo control, we should use to avoid, any episodes of hypothermia, severe hypothermia, and we need a, better temperature control by using servo control. So therapeutic hypothermia remains the most evidence-based therapy for HI, but it is not without clinical controversies. So what are the controversies? That what about the deeper and longer cooling? When should we start cooling? As early as in the delivery room? Can we start cooling within first 3 hours? Given the efficacy of therapeutic hypothermia for moderate to severe HI, when it started within 6 hours of birth, can we expand the therapy to infants with mild HI? Can we start in preterm? And what about the outcome in low middle income country? So we'll discuss by one. So let's discuss about whether the greater neuroprotections be achieved with deeper and longer cooling. So what is the rationale behind this? So in the animal model, what they found that the the in the preclinical study that they found that in the animal where the moderate and severe encephalopathy brain, they found that the deeper nuclei, that is basal ganglia and thalamic temperature, was slightly higher as compared to the the cortical regions, even if they were offered therapeutic hypothermia. So that is why the rationale is that if we can do cooling slightly deeper and for a longer period to achieve the adequate temperature of deeper nuclei to get a better outcome. So in this NICSD trial, when they used deeper, that means temperature 32 degrees Celsius as compared to 33.5 degrees Celsius, and longer period, longer here means at least for 120 hours. And they use the criteria, what they have used the inclusion criteria laid during the year of 2005, and they calculated the sample size, and what they have found that uh, primary outcome in the primary outcome there was no difference, that is death and disabilities. They cooled for deeper and longer. However, if you look at the longer duration of cooling, the deaths were higher, that is in the range of 19% as compared to a normal duration cooling, that is 72 hours. And it was statistically significant. If you look at the adjusted risk ratio, it was 1.39, and with the confidence interval between 1.02 to 1.89, it was statistically significant. However, there was no difference in the moderate to severe disability, and cerebral palsy was also not very significantly different. When we compare between 33.5 degrees Celsius to 32 degrees Celsius, again death were higher in infant those who received 32 degrees Celsius, and that means the deeper cooling. Even though this was not statistically significant, but there was an increased trend of death. Not only that, the incidence of arrhythmias, need for inhaled nitric oxides, need for ECMO were higher in infant those who received deeper and longer cooling, and the length of stay and the PPHN was also higher in the infant those who were offered deeper and longer cooling. So that is why they concluded that probably till we get the more evidence as far as therapeutic hypothermia is concerned, we should not offer deeper, that is 32 degrees Celsius, and longer, that means beyond 72 hours of cooling, and we should stick to 33.5 degrees Celsius and up to 72 hours of cooling period only. What about early hypothermia before 3 hours? So in this small study, when the infants were cooled within 3 hours of birth, they appears to have a better neurodevelopmental outcomes compared with infants whose cooling commences between 3 hours and 6 hours. There were no difference in the complications. The PDI was significantly higher in the early cooling group. MDI and CP, there was no difference. can we cool between 6 to 24 hours? So in this very small study, there was only small benefit was found in infants those were cooled between 6 to 24 hours beyond the therapeutic window. The death and disability was 24.4% in the cool group versus 27.9% in non-cool group. And even though the adjusted RR was 0.86, that is almost 15% reduction, however, it was not statistically significant. So not only that, if you cool beyond 6 hours, you may get a marginally better outcome when we look at the Bailey 3 scores, like in form of cognitive, language, and motor. However, they were actually the p-value was not that significant, and other parameters like the blindness, the hearing impedance, the seizures, there was no difference in that, and there was no statistically significant. So we should not offer as far as till we get the robust evidence, we should not offer hypothermia beyond 6 hours of life. Can we start therapeutic hypothermia in mild HI? There are many studies, but most of them are small studies. They are not robust study. So I have included this meta-analysis by an Ujjwal et al., where they've used this therapeutic hypothermia for mild neonatal encephalopathy. In this systematic reviews and meta-analysis with a small samples out, they found there was no difference in death and disabilities when they offered therapeutic hypothermia in mild HI. However, what they found that the short-term outcomes were bad in form of increased length of stay, need for, gauze feeding or assisted feeding was higher among infants, those who received therapeutic hypothermia. The incidence of coagulopathy, liver dysfunctions, cardiac dysfunctions were higher among infants, those who were offered therapeutic hypothermia for milder HI. And what they found also that the brain MRI, the injury was more in the watershed area compared to infant for moderate to encephalopathy. As we know that the infants, uh, those who develop moderate to severe encephalopathy, the injuries were more either diffuse, global, or more in the deeper nuclei like basal ganglia and thalamus. In spite of this, the if you look at the studies, they are, I mean, very often being used in USA, UK, and European country, but they haven't published their long-term data till, 2 to 5 years of data is concerned. I could not get the outcomes till 5 years of age. So because of these concerns, the American Academy of Pediatrics and National Neonatology Forum have recommended that it should not be part of standard of care. It would be very difficult to select the cases of mild HI to actually, when selecting mild HI, those who actually at high risk of developing, severe disability at 18 months of age, where we can offer therapeutic hypothermia. So we need more robust trial before we should consider this in at least in low middle income country, and we should stick to infant for moderate to severe encephalopathy as far as intervention of therapeutic hypothermia is concerned. However, people are trying erythropoietin in mild HI to get a better outcome, and we need more studies from to say that whether it is effective or not. So we have already discussed about the role of hypothermia, brain cooling in high income group countries. And what about low middle income country? We know that in the high income countries, the number needed to treat to get a benefit is very low, that is 7, with a confidence interval of 5 to 10. And but however, the benefit of this in low middle income country remains unconvincing, with different studies and systematic reviews reporting conflicting results. So let me start with this one study which was recently published in the Lancet Global Health 2021, where Professor Thile had did very, robust and remarkable studies. What this study is known as a helix trial. In this helix trial, what they have done, hypothermia for moderate or severe neonatal encephalopathy in low middle income country. It was an open label phase 3 randomized control trial with mask outcome assessments. Inclusion criteria were, they included the same methodology used in an ICSD trial, that is moderate to severe encephalopathies. They included 7 tertiary neonatal units from South Asia, that is India, Sri Lanka, and Bangladesh. In the control group, what is different from other high income group country studies that the intensive care with avoidance of hypothermia was, I mean, very properly managed. I mean, infants, though who received, I mean, usual care, they avoided any episodes of hypothermia in that, no, in normothermic group. So they maintained the core temperature 36.5 degrees Celsius. In intervention group, whole body cooling was offered. The temperature was 33.5 degrees Celsius for 72 hours using Tecotherm Neo, and they have calculated the sample size on the basis of primary outcome, death or moderate or severe disability at 18 to 22 months of age, and they have included 400 plus term infants with moderate to severe encephalopathy. Uh, Even though they published the Helix trial was published in the year 2021, but their journey started in the year 2009, and gradually they did a one feasibility study, and they published in the year probably 2011 and 13. In this study, they found that the mortality was lesser in the range of 29% compared to the normothermic group when they offer the therapeutic hypothermia, and that's why uh, they planned this Helix trial. But in the Helix trial, they used, servo controlled tacotherm to offer therapeutic hypothermia. And while doing this study, they before publications, 4 times interim analysis were done, even though the deaths were higher or comparable between the therapeutic hypothermia group and the normothermic group. But the data safety monitoring committee found that the methodology was so robust, they allowed to continue the study, and ultimately they got their study published in the Lancet Global Health. Let's see the Helix trials, the demographic status. There was, no difference between the birth weight, gestational age is concerned. The outborn babies were higher in the range of 70%, both in the hypothermic and usual care group. Cord pH were, almost same in the both group. However, only in 5% of the cases, they could be able to do a cord pH only. Intubations required in the hypothermia group was 45%, in usual care was 44. There was no difference. 80% were falling under the moderate encephalopathy, and 20% were in severe encephalopathy. And one surprising thing was that the seizure incidence was very high both in the hypothermic group and the in the usual care group. It was in the range of 74%. If you look at the outcomes, if you look at this outcome, the gastric bleeding, the persistent hypotensions, pulmonary hemorrhage, prolonged coagulation, severe thrombocytopenia, all were very high, and they all were statistically significant. However, the early onset of sepsis and the culture positive sepsis were same. It was in the range of 5 to 6%. But death before discharge was high. So it was 36% in hypothermia group versus 24% in the usual group, and it was statistically significant. The death was high until 18 months of age. In hypothermia group, death was 42%. In usual care group, it was 31% only, and it was statistically significant. Even though there was no difference in the death or moderate severe disability, that was the primary outcome, and other outcomes were statistically not significant, like microcephaly, survival without neurodisability, persistent seizure disorder, blindness, hearing impairment was comparable. When we look at the MRS, the magnetic resonance imaging, uh, looking at the thalamic and acetyl aspartate level and the lactate and Na level, they found that there was no difference in the Na level and this ratio between hypothermia group and the control group. However, studies from the high income group, they found that infant were offered therapeutic hypothermia, there was a significant difference between NNA level and lactate and acetyl acetate level. So indirectly, they were, commenting that even after offering therapeutic hypothermia, there was no difference in the deep nuclei level of MRS. So what they have concluded that therapeutic hypothermia should not be offered as treatment for neonatal encephalopathy in no low middle income group country, even when tertiary neonatal intensive care facilities are available. And what was the actual difference between the Helix and the trial versus high income group country trial? What they found that there was a difference in the birth rate. Obviously, in the low middle income country, the birth rate would be less. But the major difference was in the number of outborn babies. In Helix trial, 70% were more than 70% were outborn as compared to high income group country, where the outborn baby was just 45 to 64%. Perinatal sentinel events were found only in 11% compared to high income group country, where it was in the range of more than 40%. Emergency CS were done just 20% in Helix trial group, whereas in the high income group countries, the uh, the emergency C-sections were done in the range of 48 and up to 73% group. One surprising finding was that the hypothermia in the control group in the Helix trial was 5%. And all 5% either they die or they have got severe disability. Whereas in the high income group country, where they were not intensively monitoring the temperature of infant, those who were for those who were offered normothermia, and the normothermic group, the hypothermia was episodes of hypothermia was very high in the range of 14 to 38%. And it was found that infant who develop hypothermia, they usually develop severe disability or they would generally die. If we're looking at the MRE brain finding in the Helix trial, the major brain injury was found in the white matter injury as compared to deep nuclei injury. In the high income group country, MRI brain were showing more injury in the basal ganglia thalamus, that is deep nuclei damage. Fetal monitoring was not assessed routinely in the Helix trial because many of them were, outborn. Whereas in high income group country, it was inversely monitored. Seizure episodes were very high, 74% compared to high income group country, where it was in the range of 33 to 61%. Because of this controversy, all got confused. So during the year 2021, NNF released a position statement after doing meta-analysis. What they found that three important findings. If the admission temperature were less than 36 degree, if the infants were offered therapeutic hypothermia, the death before discharge were higher. That means infants died even if they offered therapeutic hypothermia if their admission temperature were 36 degree, less than 36 degrees Celsius. If the cord pH were not reported, not done, they found that there was no benefit of therapeutic hypothermia in these group of infant where cord pH were either not mentioned or not done. And even deaths were higher. And the third important point, they found that outborn neonates. When outborn neonates were offered therapeutic hypothermia, they found that either they don't get the benefits or it was found that deaths were statistically, though deaths were higher in infants, though in the outborn infants, if they were offered therapeutic hypothermia, and even though that were not statistically significant, but the trends were higher. If you look at the severity of HI and death, so more severe is the disease, more chances of mortality. So this was published by the Deepak Chawla group in the clinical epidemiology. So we can say that severe would be the disease, the mortality would be higher even if you offer, the best sort of treatment. So what they have uh, released the statement that NNF said that there should be some mandatory criteria. Those who wants to offer therapeutic hypothermia, there, 24 into 7 neonatologist availability should be there. There should be good quality NICU level 3 or level 4 care. They would be able to monitor, like cardiac monitoring, and they could be able to monitor, blood pressure by invasive. They should have the bedside facility of ultrasounds, EEG, MRI. There should be multidisciplinary team. They should have the facility to provide blood supports for, if required, inhaled nitric oxide if the patient develop PPHN. And they have the good developmental team so that they could be followed up to 18 months of age, and if they required, they should be offered, a good occupational therapy. That is why they recommended that therapeutic hypothermia should be offered to neonates with HI with gestational age more than 36 weeks within 6 hours of life, and with the admission temperature should be 36 to 37.4 degrees Celsius. If they fulfill all the following criteria that we have already discussed, then they can be offered therapeutic hypothermia. And they have also mentioned that during preparation for cooling, if the neonate's encephalopathy has improved, becomes mild or normal, we can think of, deferring the therapeutic hypothermia, and that group of infants can be, observed very closely. But the what the NNF have published, uh, but they have not categorized the studies based on the methodology, whether the methodology was good or robust or the bad study. What the Thayali groups and the Sankaran group published in the Lancet, they have included almost same group of studies, almost 16 or 17 studies, and they have categorized it and color coded into the on the basis of risk of bias, that is red, amber, and green color. Red color means there is a definite methodological biases, amber means mild biases, and green is, good and robust study. So when they meta-analyze, when they did a meta-analysis looking at outcome, death and disability in 18 months, they found that only Helix trial was falling under the green category. And when they looked at the outcome, there was no difference in the death and disability when they offered therapeutic hypothermia. The study from China was falling under the amber color category, and they found that there was some methodological biases, but in this study, they found that there was a reduction in the range of almost uh, 37% reduction in the death and disability at 18 months of age, and that was statistically significant. When they combined both study, and then they found that the reduction rate was 8%, and again, it was not statistically significant. When look at the mortality at hospital discharge and categorize these studies in the red, amber, and the green group, only Helix found to be under a green category studies, and they found that the mortality was higher among infant where they offer therapeutic hypothermia, and the relative risk was 1.36 with a confidence interval of 1.05 to 1.77. The 9 studies, they are falling under the amber group with the methodological biases. They also found there is a reduction in the mortality range, but it was not statistically significant. And 6 study from the same standard, which were done between 12 and 2020, they found the reduction in the mortality at discharge, uh, in the less than 40% reduction in the mortality at hospital discharge, and it was statistically significant. So if you categorize the study on the basis of the good methodology, you won't find whether this intervention is effective or not. Let's discuss about hypothermia for other conditions like the major intracranial hemorrhage, postnatal collapse, congenital heart disease, surgical condition. They've been offered, but the trials are not robust. There is no evidence of safety and efficacy. So at least we should not offer in these conditions. So what about hypothermia for preterm hypoxic ischemic encephalopathy? The American Academy of Pediatrics and National Neonatology Forum have recommended that we should offer only for infants, those who are 36 weeks and more, because only few studies have included either 35 weeks or less than 35 weeks, where we need more robust data uh, to say that whether it's effective for a preterm infants or not. The TOBI registry have reported cooling of infants who are less than 36 weeks, but they have not reported individually or long-term data for infants for less than 36 weeks. Even one registry, they have not published long-term data for infant less than 36 weeks. We have included this one single center study where they have included uh, 30 infants. What they found that in this preterm, that is 33 to 35 week baby, death and disability were higher. Either 4 died, 8 lost to follow-up. The complications rates were really higher. DIC, seizures, hypotension, persistent acidosis were really higher. So at least till we get a final answer for preterm HI, we should not offer hypothermia for preterm HI till we get the robust study. So we have answered all these 5 controversial things. And then now, which investigations correlates with long-term outcome? So let's mention about this marble studies. This marble study is a magnetic resonance spectroscopy assessment of brain injury after moderate hypothermia in neonatal encephalopathy, and it was published in the year 2019 in Lancet. What they have found that when they analyze the N-acetyl aspartate level for they found that the infant who develops develops moderate encephalopathy, the Na level is significantly lower compared to normal infants. When they look at the lactate Na ratio, again, it was, lower in normal patients as compared to in adverse infant in moderate hypothermia group, it was higher. When they look at the NNA choline ratio, infant having moderate to severe encephalopathy, they are lesser, and same thing found with NA creatinine ratio. But out of these four things, the statistically significant which correlated the outcome of with using Bailey score at 2 years of age, when they looked at the cognitive outcome, language and motor, the correlation was much better when they correlated with isolated NAA level, that is N-acetyl aspartate level. Look at the color coded. More severe is the encephalopathy, the lesser and lesser is the N-acetyl aspartate level, and the Bailey score was less. Poor for if they look at the motor outcome. Similarly, it was found with the cognitive outcome also. The more severe is the encephalopathy, lesser is the Bailey score for cognitive outcome. So overall, out of all this MRS level, the N-acetyl acetate level correlates very well with Bailey scores at 2 years of age when you compare with other investigations. If you look at the other prognostic marker, like discharge neurological examinations, with they have the sensitivity of 26%. However, with a good specificity, if you use a modified Sarnat and Sarnat staging, they have a specificity of 95%. And when the hypothermia was offered, the neurological examinations, neurological findings, they did improve. When they look at the amplitude EEG level, the sensitivity is 45% compared to specificity, that is 92%. And amplitude EEG, improve, the background pattern improve when they offered therapeutic hypothermia. When they look at the MRI brain should be done after beyond 3 days, and best time would be day 5. And after day 8, the pseudo normalizations happen. So the best time of doing MRI brain is day 5. And overall, they found in the severe encephalopathy, there is a diffuse global injury. Global means injury involving the cortex, deep nuclei, that is basal ganglia, thalamus, the posterior limb of internal capsule, as well as anterior limb of internal capsule. Out of all these, they have almost a similar sort of specificity between 80 to 90%. When the therapeutic hypothermia was offered, MRI brain got better, and when they look at the IQ outcome of more than 70, it was better as a long-term outcome. But out of all these prognostic marker, the best prognostic marker is MR spectroscopy. In MR spectroscopy, comparing these three NAA creatinine level ratio, lactate N-acetyl acetate aspartate ratio versus N-acetyl isolated NA level, it was found that NNA has got the 100% sensitivity with a nearly 97% specificity. If you look at the role of therapeutic hypothermia, looking at the level of NNA in high income group country, they found that they got better, whereas there was no difference in the low middle income group country when they look at the N-acetyl aspartate level. I'm just talking about the Helix trial. If you look at the HEAL trial, when the HEAL trial infants were followed with the MRI brain, what they have found that when the MRI brain shows global injury that include cortex, basal ganglia, thalamus, and posterior limb of internal capsule, they correlated well with the neurological outcome. However, in the mild to moderate HI with a brain damage, they found the Bailey scores were almost similar to infant with a normal neonates. So we can say that the best prognostic marker for infant falling under moderate to severe encephalopathy is MR spectroscopy and acetyl aspartate level. Now, what about hypothermia plus? People have tried various other, interventions along with therapeutic hypothermia, like noble gas like xenon, argon, melatonin. They have used erythropoietin, allopurinol in albino studies, magnesium sulfate, and acetylcysteine and cannabis. But either the trial were not robust enough, or the sample size were not adequate, and none of the studies have found better than hypothermia when they compared with hypothermia plus other adjunctive treatment. I'm just here mentioning the HEAL trial. HEAL trial is trial of hypothermia for hypoxic encephalopathy in newborn. They have included 36-weeker infants with moderate to severe encephalopathy, and the sample size were 500. They divided into two group. One group, offered therapeutic hypothermia. The other group was offered high dose of, erythropoietin, and along with therapeutic hypothermia, and they've started the treatment within 26 hours and given erythropoietin in 2 days, 3 days, 4 days, and 7 days. And they calculate the sample size on death or any neurodevelopmental impairment, and where they found that the infants, those who received therapeutic hypothermia along with erythropoietin, outcome were bad. Not only the primary outcome, but the serious adverse events were also higher in infant where therapeutic hypothermia was offered along with erythropoietin. The death, hypertension, coagulopathy, thrombosis, PPHN, need for ECMO, intracranial hemorrhage were higher in, infants, I mean, offered with therapeutic hypothermia with erythropoietin. So, at least we should not offer, because it's a very, robust trial. So, as of now, only therapeutic hypothermia is can be considered as a standard of care, not any plus treatment or erythropoietin. So I've just mentioned a case because many time fellow, your resident would get a call for emergency cesarean sections. So let's see in this example, 36-weeker baby, born depressed, because emergency c-section was done for fetal bradycardia. So at the time of birth, we required positive pressure ventilations along with intubations and chest compressions were also done. So after 10 minutes of positive pressure ventilations, the saturation was 98% with a PIP of 30 centimeter, PWEP of 5, and FiO2 of 8%, and cord pH was 7, and base excess was 18. And so she, called her senior, consultant. What they have advised that we should first optimize the treatment in form of maintain temperature, avoid hypothermia and hyperthermia. Try to optimize FiO2 because you are giving 80% of FiO2, baby is maintaining saturation 98%. Try to optimize the oxygen level. Try to optimize the ventilation settings. If your chest rises enough, try to decrease the PIP and PEEP to decrease ventilation-induced lung injury, and transport the patients in a euthermic conditions. So by the time patients reach the NICU, she has already, counseled the parents, and she told that because your baby is falling under this criteria and 36-weeker. So apart from all this treatment, we can offer therapeutic hypothermia. Because we offer therapeutic hypothermia, then we can decrease the, morbidity and, long-term outcome would be better if you offer in your baby. So at 45 minutes after counseling the parents, she called, her senior, uh, told that the saturation is 92%. Now we have optimized the ventilator setting. The patient is on assisted control ventilations with a PIP of 15 and PEEP of 5, and a FiO2 of 30%. Baby is maintaining saturation of 92%. By this time, baby, I mean, deteriorated, CFT was poor. She did an ultrasounds to optimize the fluid status. And again, after this, she called her senior again. So what her senior has told her that first optimize, try to get a nursing ratio of 1:1. I mean, uh, properly monitor the rectal temperature continuously and avoid any episodes of hyper and hypothermia, because any episodes of hypothermia would lead to either death or severe disabilities. Maintain blood sugar. If you have not put center line, put center line and try to monitor invasive BP. So optimize all these things. So we'll do, first optimize these these things, then we can consider for the other mode of management. So by 90 minutes, I mean, the saturation is 92, the same wind setting. And by this time, baby developed seizures. She applied, I mean, easy continence, CFM monitoring. And she also gave sedations after giving anti-seizure medications. Again, after 90 minutes, she called her, I mean, senior. Again, her senior told that, have you optimized all the care, temperature, rectal temperature? Have you ensured that baby is getting 1:1 ratio? Have you ensured, I mean, invasive BP monitoring? If there is a risk factor after doing blood culture, give antibiotics. And if your patient is not having further seizure, avoid maintenance drug of anti-seizure medications. Avoid sedations if possible, because I mean, sedation in this group of patients, acute kidney injury is very common. So, I mean, they would be overloaded with all sedative drugs and they would not improve the outcome of the infants. So, by 120 minutes, I mean, she was, I mean, lost her cool, and she told that, so now his patient is not spontaneously breathing, gasping. So we have already did everything, sir. So shall we start cooling or not, because it's already at 2 hours now. So again, her senior told that after optimizing all this thing, get a detailed modified sarna staging and look for whether the baby is really falling on this treatment or not. So by 180 minutes, she did a modified sarna staging, and what they found that it was a case of 36-weeker, 2.9 kg without any congenital anomaly, with severe encephalopathy on no on two inotropes with seizures. So by this time, doctor came and they told that because uh, uh, your baby, we have offered or all the treatment which is required for the baby, but still your baby is sick, and probably we can offer therapeutic hypothermia in your baby, but you should also consider that because your baby is already developed seizures, and we won't get that much of benefit with therapeutic hypothermia. And not only that, we have all the facilities for in our hospital, like blood bank, inhaled nitric oxide, MRI, MRS, and long-term monitoring. If you, I mean, if you, I mean, considering that it's going to help, but this group of baby also might require need for some blood support, might require, I mean, long-term follow-up, might require occupational therapy. If you feel that if you are ready for that, then we can offer therapeutic hypothermia in your group. So the aim is that first optimize all the things, and then we should offer therapeutic hypothermia to this group of infants. And we should not give always a rosy picture to that, because in this particular case, baby has already developed seizures at around 90 minutes of life. And what studies have found that if the infants is already developed seizures, that means brain damage has already been done, and the baby's brain is already crossed therapeutic window to get a, I mean best benefit of therapeutic hypothermia. So we should, I mean, counsel the parents accordingly and then offer them, uh, because nowadays we have to offer only one, I mean, one intervention which is going to affect the long term outcome. And if they are ready, then we should offer the therapeutic hypothermia. So the selecting the right candidate, what we have discussed in the first few slides, that first, try to maintain the temperature in the delivery room. Don't start hypothermia right in the delivery room. Optimize all the things like respiratory component, the temperature component, the cardiac component, the blood sugar, infections control, I mean, all sort of monitoring. Once you have optimized, rule out everything, that whether baby is 36 weeker or more, less than 30, I mean, more than 36 weeker. There should not be any history of fetal growth restrictions. I mean, we should rule out infections. We should offer treatment within this therapeutic window of first 6 hours. And everything, if everything is falling, then we should offer therapeutic hypothermia in this group of candidate. So to conclude that, we can say that therapeutic hypothermia at 33.5 degrees Celsius for 72 hours is safe and effective for moderate to severe HI for infant 35 weeks or more gestational age. They should fulfill all the subjective and objective criteria. We should prefer servo-control therapeutic machines. Avoid too deep, too long in preterm. If the patient is coming beyond 6 hours, we should avoid or use less and less sedations or any other treatment along with therapeutic hypothermia. Prognosis is important because we cannot wait to see outcome till 18 months of age. And out of all the prognostic markers, MR spectroscopy and acetylaspartate level is best. If you're planning to do MRI brain, avoid doing before 3 days. Best time would be the fifth day. And we should consider offering therapeutic hypothermia in infants, where you can offer cardiac IBP monitoring if you have the facility of blood bank, if you have the facility of imaging, and most important, neurodevelopmental assessment. Thank you very much.